our speaker for tonight, who is Ralph Chou. We're going to be bouncing back and forth like this a little bit this evening. So tonight, Ralph will be talking about the oldest piece of astronomical observing equipment, human eye. Just a little bit of a background. Ralph received his Bachelor of Science in Astronomy from U of T before attending Waterloo, where he received his degrees he received his Doctor of Optometry and Master of Science. As a student, he operated the first astronomical programs right here at the Science Center. During a postdoc at the City University in London, that's London, UK, not London, Ontario, Ralph began a 30-year career as a professor of optometry at Waterloo. His research interests include optics and visual effects of progressive addition lenses, and assessments of environmental and occupational hazards to the eye. He is an acknowledged world expert on solar eclipse eye safety. He's editor-in-chief of the Canadian Journal of Optometry and serves as chair of the Technical Committee on Eye and Face Protection of the Canadian Standards Association, as well as Canada's head of delegation to the International Organization for Standardization's Technical Subcommittee on Eye Protection. He was lead writer of the 2015 ISO standard for solar eclipse filters. In addition to being the president now, Ralph has been president twice before, 1986 to 1990 and 2009 to 2012. He's a life member of the Toronto Centre. He's served as assistant editor of the Journal of the RASC, and has served on National Council and as National Treasurer. Ladies and gentlemen, Dr. Ralph Chou.
Thank you. It's always fun to be able to talk about things that melt my two interests, astronomy and eye care. So let's take a trip into the eye and see what happens as our eyes age and what happens to our vision. We'll start off by taking a look at this picture of the eye. It's a stylized presentation of an eyeball, and in this case it happens to be the right eye, and we're looking at it in what we call a horizontal section. So it's like we've cut the eye this way on the face, and we're looking down at the lower half of the eyeball. And here we can see various parts of the eye that I'm going to be referring to this evening. So up at the front we have the transparent cornea, which is the window into the eye. Behind it is the crystalline lens, and here we have the iris with the hole in the middle of it, which we call the pupil. Through the vitreous chamber here we have a jelly-like material, the vitreous humor, which gives the eye its shape. And then back here we have this thin layer of tissue called the retina, which is what receives the light and turns the light energy into a visual signal, which follows the optic nerve to the brain. Around it we have some connective tissue, the sclera, which is what gives us the white of the eye, and this is what basically protects the innards of the eye. And in between the retina and the sclera is a layer called the choroid, which is a very heavily pigmented structure containing blood vessels which nourish the back of the retina. Now, we happen to have two of these in our heads, and each of them is about 25 millimeters in diameter. And in order to be able to look at anything without seeing double, what we have to do is point the eyes simultaneously, and that requires a set of muscles that are inserted into the scleral structure of the eyeball. So here we can see the stumps of what we call the medial and lateral rectus muscles. There's also another pair of muscles that are on the bottom and the top of the eyeball, which are also referred to as rectus muscles. And then in addition to that, there are two other muscles which are called the oblique muscles, which allow for some additional torquing of the eyeball. And these are connected through the brain together so that the whole set of 12 muscles will point the eyes simultaneously at whatever we want to look at. And a lot of things can go wrong with all of those kinds of nervous connections. But we're not going to really talk about the binocular, coordination. We'll be just talking about physically what can happen within the eyeball itself. So let's take a bit of a closer look at things. Could we just try and get the connection on the changer? Great. Okay, so first of all, the cornea. What's interesting about this, again, is that all of these tissues are living tissues, whether they be part of the optical train or the structure. And so we have to have some way of keeping them alive and prosperous, as it were. With the cornea, the main thing is it's got to be transparent. And so the cellular structure of the cornea is such that it fulfills a number of different functions simultaneously. First of all, the whole thing has to be kept as dehydrated as possible. And that mechanism that pumps water out of this tissue into both the front, into the tears, and into the back, into the aqueous humor, which fills the chamber immediately behind the cornea, is mediated by this thin layer of single cells layer of endothelial tissue at the back, and this more complicated structure at the front, the epithelium. The other thing is that the epithelium has to protect the cornea from the external environment. And so while this does turn over just as frequently as the cells in our skin does, it still has to remain reasonably waterproof as well as structurally resistant against all sorts of other things, including physical impact. So it's very important to protect this epithelium. The endothelium, there isn't much we can do about that except to make sure that any external types of irritants will minimally affect it. In between, we have this layer called the stroma, or substantia propria, depending on what you want to refer to. And this is collagen fiber. And it's laid down in a very, very orderly way in layers so that, in fact, the individual layers act sort of as an interference type filter to enhance transmission of the light through the structure to the innards of the eye. And again, very important that this structure be as free of unnecessary water as possible. In fact, one of the problems that we used to have when I entered practice was that with early style of contact lenses, we often got water working its way into the stroma because of the reduced oxygen level on the cornea behind the lens, and that caused the stroma to swell up, and it could cause all sorts of problems for the eye. Luckily, nowadays, modern contact lens materials have largely eliminated that as a problem. But again, one of the things about this layer is that not only does it provide transparency, but it also provides optical power. And in fact, 2/3 of the optical power of the eye to focus the light resides in the cornea. So the shape of the cornea is very, very important to ensuring that the light gets focused at the back. In addition to that, the second optical element within the eye is the crystalline lens. And the crystalline lens is an interesting piece of tissue because in the embryo, as it develops, this actually develops as an inpouching of what eventually is going to become hair and skin, among other things. So it's very related to the cornea because they originate from the same kind of tissue. The thing is that as the crystalline lens develops, it eventually gets closed off from the rest of the body. The lens tissue, or the lens cells themselves, the primary lens fibers, as we call them, right at the center of the lens, are completely cut off from the rest of the body by the secondary fibers that are laid down from the epithelial layer at the front of the lens, and they are isolated further by a fibrous capsule that surrounds the lens. So this is a living tissue that is completely cut off from the rest of the body and is cut off from direct communication with the blood supply. So all the oxygen and nutrients that keep that tissue alive diffuse through the fluids in the eye to reach the lens, and it's a very, very slowly metabolizing type of tissue. Now, this is a really important piece of tissue because it's actually fairly flexible as well as transparent in early life. And it gives us the rest of the power in the eye, and it gives us some variable power. So you're all instinctively, if you look at your watch or your smartphone or reading material, changing the focus in the eye. It's a process we call accommodation. And it happens because of the way in which the lens is mounted inside our eye. If we go back for a moment, again, I seem to have lost the, let's see if we can do this. Okay, there. If we go back to this diagram right here, here's the lens inside its capsule, and there's this ring of muscular tissue around the front of the eyeball, referred to as the ciliary body, and is indirectly connected to the lens capsule by a system of fibers that are called the suspensory ligament, which connect the ciliary body to the lens capsule. What happens when we accommodate is that the ciliary muscle contracts, and this releases the tension on these fibers. That allows the lens to bulge. And as it bulges, it increases the power of the eye and allows the object plane of the eye to move from optical infinity towards a near point. And we can, in fact, clinically measure that in the eye, and that's what we call the amplitude of accommodation. And it's something that all of you, when you go into an eye exam, get checked for until you start complaining that your arms are no longer long enough to see from near. We'll talk about that in a moment. But at any rate, so there are two refractive elements within the eye. What they are supposed to do is to focus the light onto this tissue, the retina. And here we have a light micrograph of the retina. And this schematic diagram is similar to what Ramon y Cajal, a Spanish physician of the 19th century, looked at through his light microscope and drew. And we've recognized these various forms for over 100 years. So the light is coming in this way from the front of the eye, and notice that it has to get through all of these structures before it reaches these cells back here, which are actually the light receivers or photoreceptors at the back of the eye, at the very base of the retina. So if we go from backwards to frontwards, which is the way that the signal will arise when we want to have vision, the light comes in here, passes through all of this stuff, and falls on what we call the rods and cones, the outer segments of these photoreceptors. Now what happens here is that the light interacts with a very complex pigmented pigment structure that's contained within these outer segments. There is a light-induced photochemical reaction which triggers an electrical signal which travels through the cell body here of the photoreceptor down past this outer plexiform layer into another set of cells, eventually comes to another connection to the ganglion cells, which are actually the nerve cells that will carry the signal through the nerve fiber layer to the optical nerve, and from there to the brain. So in fact, one of the things about the retina is that this part of the eye is actually an extension of the brain, a direct connection. And we can actually do a lot these days to evaluate the health of the brain by just simply looking at the retinal structures. Now, one of the revolutions that we've had over the last 4 or 5 years is that when we start taking a look at the retina, these pictures right here are based on micrographs that are done by looking at eyes that have been taken out of the head and chopped up. So all of our knowledge of what goes on inside the eye is based on light microscopy and electron microscopy on preserved tissues. But in the last few years, we've been able to use what's called optical coherence tomography to actually look at some of these structures at the cellular level in the living eye. This picture looks very similar to what I just showed, doesn't it? The difference is that this is a living eye. And the way that computerized tomography goes is that we take a look at the light that is reflected by the various tissues within the retina. It bounces back through the pupil, and we can use a computer to synthesize this view of the living cells. And as you can see, we can actually resolve individual photoreceptors in modern OCT instruments. We can actually see some of the cell bodies that belong to the photoreceptors, and we can start looking at individual ganglion cells within the retinal nerve fiber layer. So this allows us to have a much, much better idea of what is going on as we investigate problems in the eye. With this view, we see here what's called the foveal pit, which is a very important part of the retina. This is at the very center of your vision. And it's what allows you to actually look at these slides and look at my face and actually be able to see the detail. If you had the image falling just a little bit outside the fovea, say here or here, the image would be so blurred that you wouldn't be able to pick up the text that's on this slide. So the sharpness of your vision is optimal right here at the center of the foveal pit and drops off very, very rapidly as we move out of there. And in fact, when we take a look at the human photoreceptors, what we find is that the cones which are responsible for daylight vision are packed mostly into the central 2 or 3 millimeters of the retina around that fovea. The rods, on the other hand, are spread out everywhere else. Well, how many of them are there? Well, it turns out that in the entire eye, we have on the average about 6 million of these cones in each of our eyes. By contrast, there's approximately 120 million rods. So, and just think of it, all of that information from 126 million receptors has to be transferred along 1 million nerve fibers from the retina to the brain to turn it into a visual percept. So that means that those plexiform layers that I pointed out do an awful lot of processing of the image to clean it up and sharpen it up before the signal even leaves the eye. And so it means that anything that happens to that retinal structure can really screw your vision up royally. And we'll see how that can happen later on. So here's a distribution figure of how many rods we have and cones everywhere. So the cone distribution is very sharply peaked at the fovea and then drops off quite rapidly. And the rods, as you can see, there are none of them there in the fovea, and they rise very quickly to about 15 degrees temporal and about 20 or so degrees nasal of the fovea to where they're maximally located. Now, this immediately brings us to one of the important things to remember. That is that when we start looking at things at night, what we have in the center of our vision is a black hole. We have no operable vision in dim light from the fovea. It turns off. And so what do? We try to park things on the retina about, say, 15 degrees or so to either side of where we're looking straight ahead. Eccentric vision. That's why you do what you do in dim light, to look at your star charts and so on. Or, in very dim light, that's the only way that you can get your maximum resolution, by going off to the side and looking at things. Now, does it mean that the fovea is non-functional at all times at night? No. Because what we do with a telescope is concentrate light, collect it, and put it at the focus of the eyepiece. And when that light gets back to the fovea, it will have enough concentration of the light to trigger the sort of semi-daylight vision. And so you can look straight ahead, and there's enough light there that your cones are actually functioning. And in fact, in some instances, the starlight will be bright enough that you can start perceiving colors because of the fact that the cones are activated. Okay, so what happens? When we're 20 years old or so, the eyes are in perfect shape, as perfect as they're likely to be. But what happens? Well, time goes on, nature's built-in obsolescence plan kicks in, and there's no manufacturer's warranty, unfortunately. And what we find is that there are a number of things that will inevitably happen. And we'll go through some of these and how they affect capabilities to observe at night. First of all, presbyopia. Again, this is what drives most people in to see an optometrist. I've got a readout here. My arms aren't long enough. And essentially, this is a process that starts around the age of 40. Why is that happening? Well, let's think back to that crystalline lens. Remember, it's living tissue, it's still growing, it's still dividing cells and producing lens fibers. And they all have to be packed into a finite space defined by that fibrous capsule. So what happens as you increase the density of cells? Well, things get tighter and tighter. Tighter packing, less flexibility. So even under the best of circumstances, even if there's no other problem going on with the lens, presbyopia raises its ugly head. And it depends on whether you are farsighted, emmetropic, that is somebody who never needs glasses, or myopic as to when you actually might become presbyopic. Now, how many of you have never had to wear glasses up until, say, your 40s? A few of you. Okay, so you were lucky. You were either emmetropic or maybe slightly farsighted, what we call hyperopic. And you were able to accommodate as necessary if the light was not focusing exactly on the back of the eye. But as presbyopia proceeds, it becomes harder and harder to maintain that kind of focus. The more farsighted you are, the earlier the signs of presbyopia kick in. In fact, it's not unheard of for some hyperopic individuals to start needing reading glasses in their 30s. And in fact, the optical industry these days has addressed that by coming out with what they call accommodation relaxing lenses. They're basically reading glasses for them who are too young to recognize that they're presbyopic. But they are out there, and what they do is reduce the accommodative load to address this presbyopia. The other thing is that if you're myopic like me, short-sighted, you take your glasses off and everything's blurry unless it's held up somewhere close to the front of your eye. In the case of myopes, what we find is that the accommodation effects last longer, and so you don't find that your arms are shrinking until not the mid-30s, but close to 50. The myopes win. The other thing is, as a myope, if I don't want to wear glasses, I take my glasses off, I can see perfectly clearly right here. Now that might be a bit uncomfortable holding things this close, but if you happen to be about a 2 diopter myope, which puts your clear point somewhere about this distance, that's almost perfect for looking at things without your glasses. And in fact, a lot of 2 diopter myopes are a real pain for me, because when I say, oh, you need some reading glasses or bifocals, they say, no, I don't, I just take my glasses off. That happens. What about us as astronomers? Well, presbyopia is going to raise its ugly head, for sure. The problem is that when we are trying to observe at night, we often use red light to look at our reading material, right? Because it doesn't affect night adaptation, dark adaptation. The problem is red light focuses behind the eye, focuses behind the plane of the retina. That's a stimulus to accommodation. Accommodation by changing the power in the eye will pull that image forward to focus onto the back of the eye. Can you do that if you're presbyopic? No. And in fact, even some individuals who are pre-presbyopic will find it difficult to focus in red light. And so one of the problems that we have to do to deal with is dealing with that particular phenomenon. And here's just a chart that shows you the descent and fall. And you can see where you are on this graph. There's the range of values. But as you can see, it's all downhill. And theoretically, when you hit around the point where you qualify for CPP, that's when theoretically you have no accommodation left. There we go. Again, this is what's going to happen even under the best of circumstances for just about everybody. Okay, well, what can we do about it? Well, there are a number of things. Single vision reading glasses, multifocal lenses of various sorts. When I graduated, longer than I want to admit, bifocals were the standard of practice. Now, invisible bifocals are the standard of practice. And for most people, the invisible bifocal is probably the best possible use because with modern designs, these give you pretty much a seamless, clear vision from far away to right up close. And it's about the closest thing that any of us will ever get to being 20 years old again, at least for the eyes again, by using these types of lenses. For contact lens wearers, it's possible to use bifocal type contact lenses or what we call monovision, one eye corrected for distance, one eye corrected for near. These kinds of things can be done. Doesn't necessarily mean it's absolutely perfect, but it beats the alternative. And so, again, a lot of different options now for correction of presbyopia. Okay, so that's the one thing that we know is going to happen no matter what happens to us. But there's also things that happen just due to aging and the fact that as we get older, things start to go wrong. And some of these changes can be relatively benign, but some of them will lead to eye disease, and when they occur, they will also lead to perceptual changes that can affect our ability to observe at night. One of the things that I always look for when I do examine people's eyes is the shape of the eyelids, because the eyelids are controlled by a very, very complex set of muscles that hold the eyelid in place, allow it to open and close, and at the same time keep the shape of the eyelid. And if anything goes wrong with that muscular structure, we can end up with a lot of problems. Now, one thing that we all feel as we get older is the fact that we start losing muscle tone. And you know that because it's on the advertising with the news broadcasts every night. You know, there's all these protein supplements that you can take to build up your muscle. Or maybe your waistline, or maybe both. But in any case, what we do know is that the muscle tone in the lids can change the shape of the lid and can also affect the way that the eyelids will lie in relation to the eyeball. Now, the eyelids are really important for protecting the eye and also lubricating it, because with every blink that you make, what you're doing is moving the tears over the front of the eye to keep it moist. And in fact, if we start seeing problems with the eyelid, then hydration of the cornea, keeping the moisture on the front of the eye becomes a problem. And we have an example here of an eyeball where we're developing a bit of scarring because in this case, the eyelid is starting to fall away from the eye in a condition called ectropia. And when that ectropion occurs, the eyelid no longer is right up against the eyeball, and so tears can collect in the space in between, and it's sort of like a dam that's got to overflowing. The tears then start to spill down over the edge of the eyelid and spill down the cheek. Excessive watering, of course, that means that you get wet eyepieces, among other things. Ectropion is something that can be dealt with surgically if necessary, but for a lot of people it's not a huge problem. However, entropion is a much bigger problem. And this is a situation where, as you can see here in this extreme case, the eyelid has now curled up and is pointing the eyelashes up against the eyeball. Every blink, the eyeballs are getting by the eyelashes. Very, very nasty. And this really does require plastic surgery to correct it, because if it's allowed to get to this point, like this poor individual, you're going to have all sorts of problems with scarring of the cornea, a lot of damage to the conjunctiva that overlies the white of the eye, and of course you can see how badly disorganized the eyelashes are on this lower lid. So this is really something that we have to deal with very, very quickly. And again, aside from the sight-threatening aspect here, again, we have a problem with messy eyepieces because of the tears that tend to spill over that very badly deformed eyelid. Other things that can happen, well, blepharochalasis, where skin flaps start to extend over the eyelid. You get floppy eyelids, which make it difficult to keep the eye open and be able to see well. There's also a condition called ptosis, where for a number of reasons, the eyelid can no longer be retracted. And so this eyelid is permanently drooping. Now, in some cases, like myasthenia gravis, that's a very important sign because it tells you about the nerve damage. But we can get ptosis for other reasons as well. And again, if it starts to obscure the pupil like we have in this situation, of course, the problem is that you can't see well. And this is one of the few instances where, in fact, OHIP will pay for plastic surgery in order to correct this blockage of vision. So it is something that we also keep track of with patients when they come in. Moving further in, we have the pupil here in the iris, behind the cornea. And of course, the thing about this structure is that it is smooth muscle. There is a ring of muscle right around the pupil, which is called the sphincter muscle, which will close the pupil down. And then there's a set of radial muscles all the way around, which are the dilator muscle, which will open the pupil up. And depending on the light level, we get the pupil optimized to a size which will allow for the light to come into the eye without overdoing it, over-illuminating things. Now, it's important for us to know what the maximum pupil size is, because that tells you what the limitations are on the entrance pupil matching the exit pupil of your telescope. And when you're young, you generally will have a fully dilated pupil that'll be about 7 millimeters or so in diameter. And you can do the calculations according to the formulas in various books, and it'll tell you what the size of the exit pupil is. And obviously, the bigger the exit pupil, the more desirable that eyepiece happens to be. It gives you the best possible view. And in fact, when you match the pupil of the eye to the exit pupil of the telescope, that's the maximum possible view that you can have. So the thing is that for a lot of people, when we're young, we can use these eyepieces that have a 90 degree or 100 and some odd degree apparent field of view. And, we look into that and we basically get lost in it. As we get older, though, our maximum pupil size starts to shrink slightly. And as a result, what we start to do is vignette that exit pupil, and it means that we can't get as good a view through those ultra-wide eyepieces, although they'll still be reasonably comfortable to view. But we have to keep in mind that the maximum view that we enjoyed as young people won't be there as we get older. Now, a couple of interesting things about the pupil. If you've got blue or gray eyes, your pupils are actually going to be statistically significantly bigger than people like me who have dark eyes. And that's because of the melanin pigment. So blonde-haired, blue-eyed individuals tend to have very, very large pupils, and they will get to complain a lot more about glare effects, especially in sunlight. As you get older, your pupil will start to shrink down, but the lack of pigment within the eye for that light-colored iris will still represent a bit of a problem. Okay, on the average, here's what happens for light-adapted versus dark-adapted pupils. You can see that, again, on the average, you start off at about age 20 with 7 or 8 millimeter pupils, and it's downhill as you get older to age 80 when it's down to about 2 millimeters. And similarly for the light-adapted pupil, again, it's say 5 millimeters when you're 20, and it also drops to 2. Now, this has some important consequences. We've got a smaller and smaller entrance pupil to the eye. It means we've got less light coming into the back of the eye under the best of circumstances as we get older. That means our limiting magnitude that we can see with the eye is going to change as well. We won't be able to see as faint an object at 50 as we could at 20. And again, that means that we might have to rely on electronic means to do observations that we once took for granted. Okay, what else can go wrong? Well, the most common problem that we will see is cataracts. And this is something that affects the crystalline lens of the eye. Again, if you're over age 50, if I were to look in your eyes, I would probably find that you do have some form of cataract. Cataract is a general term for an opaque or hazy feature within the crystalline lens. Remember that earlier in life, generally the crystalline lens is more or less transparent. But as we get older, that tissue, which is relatively inert, can undergo some metabolic changes. And the other thing is that exposure to sunlight as we go through life has some effects on the crystalline lens. The inside of the lens is almost pure protein. And what happens is that long-wave ultraviolet radiation from sunlight will react with those proteins to turn the proteins from clear and colorless to slightly yellow. And as we get older, more and more of the lens fibers at the core of the eye, or core of the lens, turn yellow. And that's a natural consequence of aging. The other thing that will happen, as we see in this particular picture here, this is a classical example of what we call cortical cataract. This is a system of edematous changes, fluid accumulating within the superficial layers of this crystalline lens, along the borders of the individual lens fibers, which have a sort of a radial orientation. And that gives us this very pretty spoke-like appearance to the areas of haziness within this structure. What is happening, as you can see with this direct illumination, is that we're getting scattering of light, forward and backward scattering, which will decrease contrast at the plane of the retina. And you can see in this part here, this is what we call a retro-illuminated view, where we're seeing the opacified areas or hazy areas in profile from light that's bouncing off the back of the eye, back through the pupil, and illuminating these features from the back. So again, this is something that I would do when I'm taking a look at the eye with the instruments to assess what is going on. In this case, this person's got a clear area right here in the center where the pupil would be, so there's really no issue here. All of this stuff is probably well hidden by the natural position of the pupil, because in order to take this picture, we've dilated the pupil up to about 7 or 8 millimeters to see all these features. But in normal use, the pupil would be down here, and these would not be an issue, except maybe at night. Now, I can tell you, I've got cataracts, and if I take my glasses off and look at a bright star, I can actually see the shape of the cataract in my eyes. So, you know, it is something that does happen. And again, we just know that it is going on. What are the visual effects? Well, the scattered light here is going to interfere with your vision. It's worst under circumstances like bright sunlight, and all because not only do we have the glare from the scattered light, but the lens will fluoresce in bright sunlight, and that can contribute to the lack of contrast as well. Now, here's the other part, the effects of ultraviolet exposure in our environment, where the proteins in the eye are turning yellow. And in this extreme case here, you can see that not only do we have the haziness of the outer layers of this lens, but also from this view, we can see that the core of this lens is in fact very, very deep yellow. In extreme cases, in fact, it can look brown. And there's a phenomenon called brunescent cataract that we know about. What's the effect of this? Well, it acts like a short wavelength filter. In fact, it's nature's way of protecting the back of the eye, the retina, from shortwave light by taking out stuff in the front. And the penalty of that is because it's now quite yellow, we start losing sensitivity to blue and green. We don't lose it completely, but it makes it more difficult to distinguish between fine shades of blue and green as the yellowing proceeds. The other thing that can happen is that because of the change within the lens due to the cataract formation, the lens will actually swell a little bit more, which means it changes its power. And we get what is often referred to as a myopic shift. Your lens correction that you need for clear vision actually becomes a little bit more like a short-sighted correction. And quite often, even if the lens is relatively clear, we end up having to add some minus to the correction in order to optimize vision. Now, this is to be distinguished from what is sometimes called night myopia, which is a phenomenon that younger folks will experience, where if they are observing at night, they will find that even with glasses, sometimes the stars look slightly fuzzy. And if you do a refraction in low light conditions, you'll find that they need an additional quarter to a half diopter of minus sphere, more myopic correction, or less plus correction, in order to optimize their dim light vision. This actually arises from the fact that when we take a look at the shape of the cornea, it turns out that the cornea steepens as we go towards its periphery. So it's relatively flat in the center and then becomes sharply curved towards the edge. And as the pupil opens up, more of that peripheral cornea contributes to the retinal image. And in dim light conditions, that will result in the eye acting as if it's slightly more short-sighted than during day. And again, it's not uncommon for us to prescribe night myopia corrections for some of these individuals in order to be able to see clearly. The other thing that happens more towards with the cataract changes is that because of that yellowing of the lens, we lose the short wavelength ultraviolet, which sometimes can still transmit through the adult eye. And that means that if you happen to have a calcium K type solar telescope, that's the blue light of ionized calcium. In fact, if you're over the age of 50, you're going to need an electronic eyepiece to see that image because that light doesn't get through the cataract. In fact, it doesn't get through a 50-year-old relatively clear lens. And so that certainly is a problem. The other thing is that, again, because of the loss of contrast, the loss of sharpness in vision, because of the haziness, caused by the cataract, you may find that focusing your telescope is a little bit more difficult as time goes on. And again, here's the change in spectral transmission due to the yellowing of the lens. So here's a 3-day infant where we see the transmission is fairly high, even at 300 at the ultraviolet B, and then it rises very quickly to about 95% transmission for the optical spectrum. And notice that even by, say, 6 months or 8 years of age, you start losing a significant amount of the light that enters the eye. That's prevented by the ocular media from reaching the back of the eye. And of course, if you happen to be, say, 82 years old, notice that if you have a cataract in your eye and you're still looking at things, the best you can expect is somewhere about 30 or 40% of the light that is out there to reach the retina. So we're losing an awful lot with age due to the transmission changes. The other thing is that this is nature's way of protecting the back of the eye from the ultraviolet, which is very, very damaging to the eye. And in fact, that ultraviolet transmission disappears by the age of 10 as a general rule in order to optimize protection of the eye. Okay, what can we do about cataracts? Well, there's a variety of types of artificial lenses that can be put into the eye. Here's an example of one which is in the anterior chamber, in behind the cornea, and it rests on the front of the iris. This is one of the earlier types of corrections, and we still use them occasionally, but not very often, because it turns out that if we put the implant inside the fibrous capsule that the lens used to be in, and just remove the cataractous lens, we end up with the lens in its natural position, and it actually gives us far better optical performance. And so, as a rule, nowadays, cataract surgery is the most common operation done in our hospitals. It also happens to be one of the safest in these days, and there's relatively little that can go wrong. Although, again, sometimes things happen. But for the most part, the posterior chamber implant like this within the lens capsule is the way to go. The main complication is opacification of the lens capsule, but we can fix it, like in this case, by just using a laser to rupture the back surface of the capsule to open up a clear path to the back of the eye again. And again, it's a very simple type of correction. So these types of things go on all the time and very, very effective in addressing cataracts. All of these IOLs now are UV blocking since the 1980s, and there are ISO standards that dictate the type of transmission for these things. And of course, because they are UV blocking, you still have a problem with the calcium K line being able to see it through these lenses. However, the quality of vision tends to be rather good, and if you don't experience capsule opacification or haze, there's very little that can go wrong with these types of corrections. Generally, there are a number of options that you can have. For example, OHIP will cover a basic intraocular lens, but the surgeons will always give you what they call the bronze, silver, and gold treatments these days. There is what's called wavefront correction. This is the silver treatment. It's a slightly enhanced optical system where by using modern lens optimization, similar to the kinds of things I used to do with progressive lens design, you can actually improve the peripheral optics to the point where the peripheral aberrations for a dilated pupil largely disappear, and you get a much wider useful field of vision with sharp, clear vision with this type of correction. And then there's the gold level correction, which is usually quite expensive, which will end up allowing you to go through life without reading glasses, because essentially this is an accommodating lens implant. it uses that accommodation mechanism that you were using as a youth to actually change the power of the implant. And so for a lot of people, they can have this and not require reading glasses. You just need to be willing to part with the brass because they are extremely expensive. But they do work. What's on the horizon? Well, a number of people, including a couple of graduate students at Waterloo, are actually working on eye drops that will reverse some of these cataractous changes in the lens. It's probably another decade away, but but again, the idea is to use a chemical way to reverse the haziness in the superficial layers and maybe partially reverse the yellowing, although I have a lot of difficulty understanding how that can actually happen because of the way that proteins get denatured. It's very experimental, but it is being done. So we'll have to wait and see. Okay, other things. Well, we've got that vitreous chamber full of a gel. Well, we all know what happens if you leave a plate of Jell-O on the table. After a time, it starts to liquefy. Well, the jelly in your eye will also liquefy with time. And it can lead to what's called a posterior vitreous detachment, where the vitreous gel partially liquefies and starts to fall away from the retina. The problem is that the vitreous gel has points of attachment onto the front of the retina in order to hold it in place. And if there's a lot of the gel that is pulling away, then it's possible that the traction force that is occurring as that vitreous sags away from the back of the eye can in fact start to create small bubbles and in fact may exert enough force on the retina to start pulling it away from the back of the eye, giving you a retinal tear or detachment. And that's what we want to avoid because if we have that happening where the retina gets damaged, we can end up with some loss of visual field in that affected area. And so again, this is something that we need to watch for in looking at the eye exam. Here's an example where this area has detached from the underlying retinal structures. The retina has come up, and you can see that this area is not quite as sharply imaged as over here or over here. In fact, here's the tear, which the liquid has gone in underneath to outpouch the retina. And this kind of thing needs to be sealed up and in order to prevent any further damage from being done. Again, this is something that happens relatively frequently, so it's something that requires a dilated fundus exam in order to find it. But obviously, if retina is detached like this, you're going to end up with a blind area in the visual field. The other things that can happen are basically due to disturbances of metabolism. So here's a normal retina from somebody who's around 25 or so. Here we have an example of what's called dry age-related macular degeneration. And what we're seeing here is degenerative changes at the back of the eye in the retina caused this yellowing here by the breakdown of lipofuscin, which is a pigmented material that is present in the retina itself and can start to show up as the retina ages. And these white spots here are what we call drusen, which are basically degenerative products that arise as photoreceptors and other cells within the retina start to lose their physiological functions. And they start depositing materials in the retina instead of having them carried away in the blood. Now, this is a relatively benign condition. Even with this kind of appearance, the vision can be still fairly good. What we hope never to see is an example of this, which is wet macular degeneration. Because this is a disease within the eye caused by the development of blood vessels underneath the retina. They basically grow out from the underlying choroid, and when these blood vessels grow underneath the photoreceptors, they can often rupture, and this is the result of the scarring that occurs as the body tries to clear away that blood from the back of the eye. We hope never to see this when we look inside an eye, but unfortunately, there are quite a few people who suffer from that condition. Essentially, all of these changes will affect your visual acuity at some point. They can, if they affect the fovea, change your color vision as well. And, of course, they can also, because of light scattering effects, change your ability to distinguish contrast. So, unless it's a very, very high contrast target, you may start losing things. Again, if we think about typically what astronomical objects look like nebulae and so on, your contrast is about 20 to 40% in those cases, and those would be at the threshold of where you would start losing things if you started getting really severe changes like this towards the central part of the retina. The other thing is that these can cause distortions, which we cannot correct. And so again, that could be a problem. Other areas where the low contrast detail will present a problem is looking at the sun through the H-alpha and calcium K-type telescopes. And again, most of us use the H-alpha. Again, you'll recall that there's very, very low contrast there. Even under the best of circumstances, filaments are about maybe 10% contrast unless they're massive. And so they are a challenge at the best of times. And as these retinal changes go on, our ability to pick those things up get worse and worse. Okay, we're almost to the end. Now those things are not too bad. There are other things, though, that can mess things up too. And here's the four that I'll finish off with, because these are the major problems that I tend to see with people who come in for eye exams over the age of 50. Dry eye particularly is one problem. And there are many reasons for dry eye. Getting old is one, because we all undergo various types of hormonal changes as we get older. As women go into menopause, one of the side effects of menopause is a loss of mucus-producing cells on the mucous membranes, which means that every mucous membrane gets dry. Now, that in itself is not bad, but if there are other things going on, like arthritis or some of the other collagen-type autoimmune diseases, that can make life miserable for those individuals. Men can get the same kind of thing, but it tends not to be quite as severe. But it can be in rare cases. With these kinds of things, the dry eye will cause blurred vision, glare and decreased contrast, and again, under windy conditions, your eyes can become extremely uncomfortable to the point where you can't even open the eyes up. A lot of the time we can deal with that with various types of lubricant drops, and nowadays there are a lot of preparations being sold now which contain hyaluronic acid, which is much, much more effective at dealing with dry eye than the saline drops that we used to use at artificial tears. And this can go a long way towards making life a lot easier for people with dry eye, no matter what. Diabetes is another problem that we see a lot of. There's probably a few people in this room who have adult onset or type 2 diabetes. And again, one of the things that we are very aware of is the fact that control of the blood sugars in diabetes are very important to prevent the natural consequences of diabetes from progressing beyond what we call background retinopathy. This is a typical moderately advanced diabetic eye where we're seeing drusenoid-type deposits. We have flame hemorrhages where the blood vessels are starting to leak into the nerve fiber layer. We have cotton wool spots, which are capillaries that have now been blocked off, and they're causing a lack of blood to opacify or haze up some of the nerve fiber layers. There's a lot of different things that are going on here, which can lead to blurred vision, correct prescription changes in the corrective lenses that you need, and it's not uncommon for people who have relatively hard to control diabetes to experience variable vision that can change from hour to hour, if not day to day. And again, that kind of situation, if they have poor control, is very ominous, because what it means is that they are much more likely to advance from background to what is called proliferative diabetes. And this is a sight-threatening condition. In this instance here, this is early proliferative diabetes, changes at the back of the eye. We can see capillaries that are growing out from the middle of the optic nerve, from the central retinal artery here. You can see also some hemorrhaging on the edge of the disc. There's more hemorrhages all over the place, what we call dots and blots. And basically, this is an eye in trouble. And the only recourse when we see this is to do what is called focal panretinal photocoagulation. So what the eye surgeon is doing in this case is deliberately wiping out the peripheral retina. The cone population he has to protect from this problem by wiping out the rods. And these are individual laser burns to destroy the peripheral retina, to reduce the oxygen load of the eye, to prevent the proliferation of blood vessels. And you can imagine what this person's visual fields under dim lighting must look like. There isn't any. This is somebody who definitely would be told, don't drive at night. In fact, don't go out at night, because you're not going to be able to see anything if you get out of a street-lit area. That's how severe the changes are in this case. So, again, if you're diabetic, a word to the wise, make sure that you are keeping good track of your blood sugars, and that you keep going to see your physicians and your eye care people to make sure that this thing doesn't happen to you. The other thing that a lot of us have, including myself, is high blood pressure or hypertension. Again, under most circumstances, it's well controlled, but a lot of people don't know they have high blood pressure. And if the blood pressure gets very, very high, then what we can have is a shutdown of the blood vessels, either as they come into the eye from the optic nerve, or once the blood vessels branch out and we can have an occlusion of one of these branch arteries. When that happens, it's like having a stroke. The affected part of the retina dies, and we end up with a field defect. And in fact, the unfortunate thing is that a lot of people get a branch occlusion or a central artery occlusion as the first sign that they have high blood pressure. And while we can get them under treatment with their physicians, we can't save the vision in the eye. So again, as we get older, it's really important to make sure that you are checking your health. The loss of vision can mean that you'll have problems with taking advantage of your full eyepiece field, and of course, in the extreme event, if it's a central retinal artery blockage, you end up with the eye being blinded. So again, not a good thing. The other thing is we're seeing a lot more people with glaucoma, which is pressure in the eye that is too high to sustain neural health. So this is a disease where the pressure in the eyeball is high enough that it damages the nerve fibers before they get to the optic nerve. And uncorrected, it can cause tunnel vision and eventual complete blindness of the eye. And again, the whole purpose of detecting and then treating glaucoma is to reduce the pressure to the point where we protect the nerve from further damage. And unfortunately, we can't get back a lost visual field, but you can at least stabilize the visual field so the losses don't progress. So really, what do we do? We've got to protect what we've got and keep it. And again, regular eye exams are definitely something that we need to do to update any correction that's needed, check the ocular health, and manage any eye disease that may be there. The other thing is that we know that nutrition plays an important role in maintaining the health of the visual system. We can also do a lot to protect the eye from various things like ultraviolet and sunlight. And we know that a lot of plastic lenses that are out there today that have largely replaced glass in the market are very good at inherently protecting the eye from ultraviolet. So again, if you ever go in and they try to convince you that you need ultraviolet protection, well, it depends on the type of lens you're using, but if it's any of these new urethane types lenses or polycarbonate, you don't need anything special to protect your eyes from the UV. I'll just skip through this to talk about transitions lenses. These are the modern lenses that change color in the light. And they're available now in gray, brown, and green for general purpose lenses. They can be used for both indoor and outdoor use. And again, the nice thing about the plastic photochromics is that they cut off sharply at 400. So they give you very good ultraviolet protection. The problem is, again, for calcium K-line, well, K-line is right there, just on the wrong side of the border. Okay, so the other thing about these lens materials is that not only do they protect against ultraviolet, but they are also considerably stronger than glass. They're not bulletproof, but some of them are not bad. To give you an example, in some of the research I do, I fire BB pellets at spectacle lenses to see what they'll stand up to. With polycarbonate, even if it's 2 millimeters thick, I need to hit it with a steel ball bearing, which is 6 millimeters in diameter. It's got to be traveling at something like about 200 and some odd meters per second before I'll break that lens. By contrast, a glass lens, I can shatter it with a ball bearing that's going about 30 meters per second. So some of these materials are extremely tough, and you just need to have them in a frame that will hold them in place to give you good protection. Contact lenses, too, have ultraviolet filters in them, so there's a number of these lens materials that give you quite good coverage from the UVA. But UVB down here, yeah, it's sort of, well, some of them do, some of them don't. Generally, I would not rely on a contact lens for ultraviolet protection of the eye anyway, just as a general principle, because they only cover the cornea, they don't protect the rest of the eyeball. So if you're wearing contact lenses, you need sunglasses anyway. Okay, let's just move on. Dietary things, because this is the other growth industry that we see. Types of dietary supplements to protect the vision. Well, there's no doubt that ultraviolet damage can be prevented to a certain degree by having a diet that's rich in antioxidants. So vitamins A, C, and E do contribute. We do know that there's a lot of preparations out there that you can see on the drugstore shelves that contain lutein, which we know is protective for the retina against dry maculopathy. But a lot of those preparations really are the type where they don't really prevent maculopathy from occurring, but rather you start taking them when the first signs occur in the retina, because what they do is stop the further development of the changes. They don't really prevent the thing from actually initializing. One of the other things, not as many people smoke, but what we do find is that if you use some of these preparations and have a history of tobacco use, in fact, beta-carotene that is in some of these preparations is a big red flag, because with people who have used tobacco in earlier life, if they use these types of materials to try and prevent eye damage, they make themselves more vulnerable to development of lung cancer. So it's something that you need to talk to your physician about before you start taking these things. In fact, general rule is any kind of these nutritional supplements, talk to your physician first before you start taking them to make sure that, in fact, they don't put you at risk of other conditions. Okay, I think we should have one more slide to go on. I'm not getting it. There. Okay, for diabetes, again, we want to stabilize vision by controlling the blood sugar levels to prevent the complications from arising. Hypertension, the same kind of thing, diet, exercise, and medication as necessary. With glaucoma, again, what we want to do is slow the progression of the disease. We can't actually stop it, but what we hope to do is make sure that it doesn't reach the end stage before the rest of you does. And that's the hard and fast way of dealing with it. So there are a lot of things that we can do. But remember, at the end of the day, it's always a competition between old age and experience and youth and skill. So now you know what you need to do to keep what you got. Good luck.
Whatever way to put it, the eyes have it.
Okay, questions? Okay, we'll start here. Yeah.
So it sounds like we shouldn't wear our glasses if we're looking through a custom case scope.
Well, yes and no. The problem is that, yes, the glasses may block the view. The caveat is you've got to have enough focusing range to compensate for your refractive error. And I'm not sure whether that works very well for everyone.
Maybe you speak about wearing glasses with a telescope.
Okay, there's various schools of thought about that. Because I have fairly significant astigmatism, I use my glasses all the time. There are other people who have more of a spherical correction where, in fact, you can take the glasses off and you can rack the eyepiece a little bit more and get a good focus without having to use your corrected lenses. I think it's very highly personal choice and really depends on how you've learned to use the telescope. Like, I would never look in any kind of optical instrument without my glasses on. Whereas, I've got other colleagues who have spherical corrections, they just, okay, let's take a look. So it's an individual choice. I would say that for the most part, especially if you don't have eyepieces that have long eye relief. So if you've got, say, a short focal length Plössl or a short focal length Kellner, with those types of lenses that have very, very short eye relief, you may have to take your glasses off anyway in order to be able to really use the eyepiece well. Now, the one thing that puts you at an advantage is that we have what's called the equivalent spherical focus. And that is that for every astigmatic eye, there is a certain spherical lens power that will produce a minimum blur at the back of the eye that is indistinguishable from basically it's the sharp focus for that eye. And if your astigmatism is not too severe, in fact, you can use that equivalent sphere setting to allow you to look at the images relatively sharply through the eyepiece without the glasses. But what you'll find is that if you really compare yourself with somebody who has never had to wear glasses, they'll see something that you can't because there's just that little bit of blur that will end up with your limiting magnitude being just a little bit brighter than theirs. Okay, there was a question. Yeah.
Yeah, well, I've enjoyed your talk, but I have a couple of questions. Did you say all glasses have UV protection, even normal glasses?
If they are made out of these resin materials.
The resin materials?
Yeah. Now, there is optical plastic, what we call CR39. That has very little in the way of UV protection. But it can be enhanced by what's called a UV 400 treatment. But if you have some of these urethane lenses that are higher refractive index plastics, so 1.56, 1.6, 1.63, these types of lenses are now being used, especially in more premium type lenses, because they give you thinner, flatter lenses. They look a little bit nicer. They're a little bit more expensive, but the trade-off is you get better optics and you also have that UV protection.
I'm getting new glasses.
So talk to the optician about looking at some of these higher index resin lenses.
Higher resin?
Higher index resin lenses.
That's what I thought you said. Okay,
And
my
those
second
were-
question is, you mentioned there are better products for dry eyes.
Mhm.
Is it prescription or is it over the counter?
There's a mixture of these substances. There are some that are in fact prescription, and those are for extreme dry eye conditions. For a lot of people that have mild dry eye, there's a lot of very nice non-prescription products available. Just talk to the pharmacist and they can point you in the right direction. The thing that you're looking for with these non-prescription preparations is that they will either be gel drops or gel type products containing hyaluronic acid. And that's a very, very viscous material that helps to reinforce the tears. And they do a really good job. Now, I've had dry eyes to the point, ever since I was in my teens, and I use those types of things all the time. You know, my eyes are dry enough that when they tried to fit me as a student with soft contact lenses, those were hydrogels that had 38% water content. When they put them on my eyes, they turned into saran wrap. And that was hard to get out. So I use that kind of drop all the time. You know, I've always got these types of drops with me, and the hyaluronic acid drops are the best stuff I've ever experienced. They're really quite good. Okay, Aaron.
Yes. If my lenses are yellowing, would I necessarily realize it?
Probably not. The problem is that, you know, you look through those eyes every day. And it's just like looking at any other part of your body. If you see your body every day, you don't notice the change.
Right.
But, you know, somebody who looks at your eyes, say, every couple of years, they'll notice that change very, very readily. The yellowing in the crystalline lens is very, very slow. And so it's not likely something that you're going to notice unless, you know, you take serial views, say, a year or so apart, then it becomes obvious. But from a daily thing, no. About the only indication that you have that things may be going awry is that you may find that, you know, certain shades of blue start looking grayish instead of what you recall as blue. And that's a reflection of the fact that not enough blue light is getting into the eye to give you that color sensation.
If I were to go through a cataract procedure and have the lenses replaced, right now, even distance, I have to use +1.
Well,
What would happen then if I get an artificial lens?
okay.
Would it be like a +1?
Yeah, that's a very, very good question. What gets done nowadays is that as part of the pre-cataract extraction workup, the surgeon will actually have an ultrasound scan done of your eye so that they can measure the exact axial length of the eyeball. They've got the measurement of the optical power of the cornea. So the lens power for the implant is chosen. And again, it can be customized. For a lot of people, what they do is they will choose a lens that, as far as the spherical component of the power of the eye is concerned, will put the distance object right on your fovea. So that basically, you get that lens, you don't need a correction for distance vision anymore. Now, there are some people who, in fact, decide that they like their glasses, they're so used to their glasses that they want to have glasses. And so they can modify the lens implant power to give them any kind of correction that they want.
For example, if I chose I want to be able to look at my computer without glasses, that means I'm going to have to use negatives for distance, right?
Yeah, and that could be done, although the surgeon would probably try his or her level best to dissuade you,
Yes, I
because there would be problems. But again, there are a lot of different options that are available when it comes to cataract extraction. And you know, one of the things that I found over a 40-year career in the eye care business is that, you know, I can confidently predict that my patients have a 95% success probability of going into that cataract extraction and coming out with really good vision. Contrast that to when I entered practice 40 years ago, when I had less than a 50% chance that that patient would emerge with any usable vision with cataract extractions of those days. In fact, they were more likely to come out blind. So, you know, it's just a difference in the technology that makes it that much different for the outcome.
Thank you.
Now, question down here. Okay, yeah?
I have a slightly different question.
Yeah.
I know it was a whole litany of words you gave us because we're all getting older, but I know that humans are a highly visual species. But how does our eyesight compare to other animal kingdom, like for eagles can see a
No, that's a really interesting question. Not quite about what I was talking about tonight, but you know, we do studies of comparative vision. And yes, indeed, there are some animals, ground squirrels, raptors, that have extremely sharp vision. If we use the visual acuity standard that we normally use for human vision, these particular creatures have visual acuities that are somewhere like 25 over 5 to 20 over 10, compared to human vision, where about the best we can expect for most humans is about 20/15. Okay, so essentially, what 20/15 translates into is a minimum angle of resolution of about 3/4 of a minute of arc, 45 seconds. Whereas these critters are looking at, you know, less than 30 seconds of arc resolution. So, you know, it's far, far better than ours. On the other hand, you do have dogs and cats whose vision is probably around the equivalent of about 20/30 to 20/40. So they're all over the place. It depends on what they need their vision for. Okay, question there.
Just coming back to the UV issue again, if I may. Do polarized or sunglasses have better protection than these that have UV 400?
Yes, they do, because the polarizing membrane that's put into a polarizing sunglass is inherently UV blocking. And so it doesn't matter whether you've got glass or plastic polarizing lenses, they will block the UV quite effectively.
Well, these are supposed to block the UV.
Yeah, in fact, it's interesting that the optical industry has now developed a very nice photochromic material, which is almost what we call pure white, that is clear, indoors. When you put it into sunlight, it becomes both a sun lens and a polarizing lens. So it's a polarizing sunglass in the sunlight, perfectly transparent indoors. Again, it can be extremely useful for a lot of people. Now, one of the things that you have to be careful about polarizing lenses, typically when you look at the plane of transmission of polarizing lenses, it tends to be oriented so that the planes of polarization are vertical. And the reason for that is because most glare that we encounter from water or from road surfaces is with the polarization vector horizontal. So if you've got a vertical axis of transmission, what it means is that the horizontally polarized light that contributes to glare will be blocked. The problem is that if you take a look at car displays these days, you know, anybody got a data display in their car dashboard? Who's got a heads-up display as well? Those are all polarized. And it turns out the plane of polarization of those displays is horizontal. So, in fact, what we've seen is a lot of non-prescription sunglasses that are made with obliquely oriented polarization axis in the lenses. You got one eye oriented this way and the other one with its plane of polarization this way, so that when you look at the polarized display, each eye gets a piece of it. And the thing is that visual perception is funny because we have what's called binocular summation. You get a little bit from the right eye, you get a little bit from the left eye, the brain mashes them together to give you the full picture. And so you're missing a little bit from the right eye, a little bit from the left eye, and they perceptually get filled in so you see everything with both eyes. Heaven help you if you close one eye. Okay, Tony.
Ralph, is there any risk in indoor lighting for UV from fluorescent or LED? Is that not?
Another very good question. LED lamps are very restrictive in what they are producing. It depends on the type of color that the lamp is rated for. The higher the coordinated color temperature, the bluer the emission happens to be. So, the earliest of the LED lamps were rated at about a 5,000 to 5,500 degree color. So they're very, very blue and they're very, very glaring. The more recent lamps are rated at about 2,500 to 3,000 K. They are definitely a lot less glaring, and you notice that they appear to be much redder in their emission. And in fact, you're probably better off illuminating things with the 3,000 lights, because they give you enough usable light without over emitting blue. The problem with blue light, especially in sleeping quarters, is that even at interior lighting levels, if you've got a lot of blue light that is around 440 nanometers or so, what it does is turn off your melatonin cycle, and that means sleep disruption. So if you have LEDs in your home and you're having problem with sleeping at night, you might want to check the lamps that you're using. You want to shift everything to these redder types of lamps to enhance the sleep cycle, especially in the evenings before you hit the hay.
What about the fluorescent tubes that are common in workplaces?
They are fairly bright in the blue, but not. It's not quite at the same wave band as what affects the melatonin level. So it's not quite as much of a concern there.
Okay.
But it depends on the type of fluorescent. No, Tom.
In addition to things like cataracts being healed by eye drops, anything else interesting coming down the pipe potentially in terms of the future of eye care, perhaps as far as ocular implants?
Yeah. Well, what we are seeing is a lot of work on electro-optical implants at the retinal level. Now, the main concern there is to deal with people who have very poor vision as a result of genetic retinal disease, like Best's disease and a couple of things like that, where by the time they're 20, they're basically blind. And the idea there is to replace the damaged photoreceptors with an electronic sensor array, which can be hooked up to the optic nerve. And this is actually going on now. There's a few of these systems being experimented with for these individuals where they are actually getting some useful vision with these types of devices. So that's one of the things on the horizon. The other thing that we're looking at is genetic therapies, which will allow for regeneration of damaged photoreceptors and things like that. Again, highly experimental. They're not really at the stage beyond animal research at this point, but the idea would be to try and put viruses into the eye with the genetic codes that would allow stem cells to regenerate damaged photoreceptors and things like that. The idea, obviously, is try to reverse the effects of age-related maculopathy.
So we're still a few decades from being able to tap the side of your head and switch to H out.
Yeah, I'm afraid so. Okay.
Ralph, you mentioned that beta carotene was counterindicated for smokers. How long do you have to be a former smoker for that?
Excellent question. We don't know. We do know that it does make them more vulnerable, but we do not know how long it has to be that you're smoke-free or tobacco-free before that is statistically less significant. So at this point, we're basically saying if you've had any kind of history of smoking or tobacco use, then the beta-carotene type supplements are definitely out.
That's not the answer I wanted to get.
Sorry. But, we do have smokers' formulas as a result. So that's why we've got them. Okay, question up there.
Earlier you said that you're seeing more cases of glaucoma now.
Yeah.
Why?
Well, I think it's because we're much better at detecting the problems. We measure pressure, we look at visual fields, and what we're seeing is that there's a lot more people showing up with eye pressures that are lower than what we typically have considered to be glaucomatous that have these kinds of field losses. Normal tension, as we call it, normal tension glaucoma and low tension glaucomas are on the rise. And this is something that is totally unexpected. We used to think that the critical difference was an eye pressure of 22 millimeters or so of mercury. But now we're seeing a lot of people showing up with what we would consider normal levels of eye pressure, 14 or 15 millimeters, that have these problems. So, why this is going on, we don't know, but we're seeing this and these people are being put into treatment. The problem is that there is a balance between intraocular pressure and perfusion pressure of the blood moving into the eye that you have to maintain for good health. If you bring the pressure too low in the eye, it upsets the vascular dynamics and can really mess up perfusion. So it's very, very difficult to handle that.
Thank you.
Yeah. Frank?
Are there any natural healing techniques or exercises or relaxation sort of techniques that help the eye to recover and heal from stresses as efficiently as possible?
Again, very good question. And the answer that I have is I simply do not know. There are people who are trying to use some of these relaxation methods and so on. How successful they are, I don't know. I see a lot of unsolicited internet messages about, throw your eyeglasses away and, do all these things. And when you really look at what they're doing, it doesn't work. It didn't work when they tried it 100 years ago. There's no reason to expect it to work today. And, so it's just one of those things. Yeah.
Automobile glass. Should people who don't wear glasses wear sunglasses in a car?
Having done all the work on solar ultraviolet and industrial ultraviolet and so on, I would say that the best preventative that you can have for environmental exposure is sunglasses and a broad-brimmed hat. From as early in life as you can put them on a person and just keep using them. Because we know that solar ultraviolet is the biggest key to a lot of these degenerative changes that go on inside the eye. And from a preventive point of view, it's the least expensive, most convenient way of preventing a lot of these problems.
Ralph? Okay, we'll take one last question.
Right.
Do you have an opinion on wearing glasses versus the laser corrective surgery?
Okay, that's a very good question as well. With the types of operations that are being done now for refractive surgery, there's less concern about fragility of the eyeball, for example. However, there are limits on what you can do. For example, most eye surgeons, if they really are being honest with you, will tell you that there's a very, very restricted range of refractive errors. Myopic, generally between about 1 and 3 diopters of sphere in myopic errors that are very well treated by these methods. If you try to do hyperopic corrections or higher myopes, what you find is that the correction works for a year or two, and then you start seeing drift. In extreme ranges, the drift will be back to the original preoperative correction. In worst cases, what you end up with is irregular astigmatism, which no optical correction will then be able to deal with. And the other problem is that one of these procedures done in youth makes a real hash of correcting a cataract eye afterward, because the optics are so badly screwed up as a result. So, basically, there are very few people who I would recommend have the procedure done unless there is some kind of overriding reason for career or something like that. But generally speaking, the payoff is not really worth it for a lot of people. The other thing for us as observers at night is, remember, your pupil opens up, and in refractive correction, refractive surgery, what they're really doing is concentrating on the central 4 or 5 millimeters. So if you happen to be one of these people with a large pupil, when your eyes open up, if you've got a 7 millimeter pupil, you're going to get monocular double vision, because you'll have a focus for the operated section, and then you'll have a focus for the unoperated area that the now dilated pupil is allowing to get back to. And so it can create all sorts of interesting problems.
Ralph, thank you very much. And clearly the audience enjoyed it because they didn't even let me finish.